All right, party people, we are back at it with another one. Let's get it. So we've got a 25-year-old female with some hand pain, a normal physical. She's positive for type 1 diabetes. Currently, she's taking ibuprofen for her hand pain, as well as a history of pericarditis about a year ago. Her hand x-ray is normal, and she has antibodies at citrullinated proteins. Now, the question will ask you, what other types of antibodies will she have? And out of the option choices below, please make your pick. 3, 2, 1, peekaboo. All right, let's run through it, see why the correct is correct and the incorrects are incorrect. When analyzing the question itself, the first real signal that you get is that she has type 1 diabetes. Also, she was hospitalized about a year ago for pericarditis. It's there for you to connect this in terms of what she might be suffering from. Now, in the case of autoimmune diseases, you have to know that they come together. Think of them in clusters. Type 1 diabetes is autoimmune. Pericarditis can also be autoimmune as well. So right now, your radar should be up for thinking about various autoimmune disorders that can affect her in this way. So we should be thinking about things like rheumatoid arthritis, lupus, Hashimoto's, pernicious anemia. Now, as a side note, I also want to mention that type 1 diabetes as well as rheumatoid arthritis are both loosely associated with HLA-DR3. Now, I'm not asking you to memorize these HLA charts, but in case you do have the memory to remember it, it's worth noting. Now, in terms of the x-ray being normal, don't get too excited because rheumatoid arthritis can have a normal x-ray, especially in the early years. She's only 25. So in 5 to 10 years, you might be seeing boutonniere deformities, swan neck deformities, or ulnar deviation. But just because the x-ray is normal does not mean that it's not RA. Now let's get into the specifics. She's positive for autoantibodies against citrullinated proteins. That's anti-CCP, cyclic citrullinated peptide. Now, this is the most specific and the most sensitive for rheumatoid arthritis. This is better than rheumatoid factor. Then the question asks you what other antibody will be seen in this patient, and the answer we're looking for is rheumatoid factor. Rheumatoid factor isn't actually on the list. We need to know what rheumatoid factor is. Rheumatoid factor is an IgM antibody that targets the Fc portion of IgG. I know this is strange, but they like testing it, so we're going to go over it. So again, IgM targets the Fc region of IgG. If you see a question where they ask, what's the target of rheumatoid factor? The answer is immunoglobulins, like we have here. So we're going to run through the other high-yield antibodies that you need to know, starting with anti-centromere. This is associated with limited scleroderma. Think CREST syndrome. Anti-SCL70, this is diffuse scleroderma. Anti-double-stranded DNA, you're thinking lupus. Specifically for renal involvement, this rises with flares. As far as anti-Smith antibodies, this is more specific for lupus than double-stranded DNA. Anti-histone antibodies is relevant for drug-induced lupus. Now, in terms of the drugs for drug-induced lupus, we're thinking minocycline, isoniazid, hydralazine, procainamide, and penicillamine. Not penicillin. Penicillamine is a copper chelator used in Wilson's disease. Moving on to HLA-B27. It's linked for the seronegative spondyloarthropathies. Just remember PAIR, psoriatic arthritis, ankylosing spondylitis, and IBD, that's irritable bowel disease, IBD-associated arthritis. You can also have reactive arthritis. Now, you need to know that HLA-B27 is never diagnostic on its own. It supports a diagnosis. You use HLA-B27 as a diagnostic tool, but you're never going to order it right from the jump on its own. This is something to be used in conjunction with other indicators. Now, as far as U1RNP, this is for mixed connective tissue disease, MCTD. The combination that you need to remember is SLE scleroderma and polymyositis. This will not usually show up on your licensing exam. I mean, it's good that you know it, but this is a less common question that they might hit you with. Now, if you do run across a U1RNP positive patient, the mixed picture leads you to the answer, meaning that if you see a patient that looks like they have lupus mixed with scleroderma and polymyositis, now you want to be thinking about MCTD. But otherwise, try to skate past it. All right, let's spin the block and wrap this up. As far as anti-CCP, we're thinking that this is the most specific and sensitive for rheumatoid arthritis. As far as rheumatoid factor, this is IgM targeting the Fc portion of IgG. You have to know that autoimmune disorders tend to cluster together. This is a key point, and they give you this information on purpose. So if you see the patient has a sibling also with an autoimmune disorder, that also works. You have to know that they go together. So it doesn't mean that it can only be in the patient. It can also be in first-degree relative, all right? That's it for this one. Go crush it.